Good afternoon, everyone, and welcome to today's webinar. We are still continuing with the Pediatric Oncology series, just coming out of the Childhood Cancer Awareness Month. And today we are going to focus on nutrition for the children with cancer. My name is Dr. Irene Nzamu. I'm a pediatric hemato-oncologist working at Kenyatta National Hospital. Today we are privileged to have our speaker, who is Professor Elena Ladas. Elena comes to us from the Division of Pediatric Hematology and Oncology and Stem Cell Transplant at Columbia University Irving Medical Center. She has done a lot of work in terms of research and in terms of collaborations about nutrition, specifically for childhood cancer. She's a holder of a master's degree in nutrition biochemistry from the Institute of Human Nutrition at Columbia University Medical Center. She's a clinical investigator as well, with a lot of expertise in clinical integration and scientific evaluation of nutrition and complementary medicine in pediatric oncology. We are privileged to have her this afternoon, and we welcome her to take us through nutrition in childhood cancer. Welcome, Prof. Elena. We look forward to hearing your talk today.
Thank you, Dr. Irene, and thank you for inviting me to discuss this topic that is near and dear to my heart and so important in the setting of childhood cancer. So without any further ado, let me share my screen. Okay. Okay, can everyone see my screen?
Yes, Prof, we can see your screen.
Okay, great. Okay, so I'm going to talk about, providing the basics of providing nutrition care for children with cancer, adaptations and consideration for the LMIC setting, and, why we're actually doing this and why Columbia University via IPAN has established this very long-standing relationship with Kenyatta National Hospital. So let's just start with a few definitions. So malnutrition. Historically, when we thought about children with cancer, we really thought of undernutrition. But as we all well know, there's now a double burden of malnutrition, both in under and overnutrition. And what we found in childhood cancer is that both of these factors, both being severely underweight as well as being overweight or obese, both linked to poor clinical outcomes. It's very important for us to monitor nutrition during childhood cancer. In contrast to adults, the ultimate goal is to foster healthy and normal growth and development while the patient can receive the life-saving therapy they need. And we do this through a number of ways, monitoring patterns of growth. We look at changes in body composition and how that relates, as well as collecting dietary data. And then finally, which I'll highlight on a bit in my talk, the importance of research and, why all of this matters and why we're spending our time doing all of this work. So we know that there's disparities in treatment outcomes. We know that if a child is diagnosed with cancer in the high-income setting, their survival is relatively good. Overall survival for childhood cancer in the high-income setting is about 70%, and that goes up to almost 96, 98% for some of the very treatable conditions, such as standard risk acute lymphoblastic leukemia, as well as Hodgkin's disease. Now, when you turn that to the LMIC setting, survival is quite different. And there's a number of different factors for this. But what I want to bring your attention to are these two factors here. Treatment-related toxicity, which is here in this purple, as well as treatment completion. Both of these factors have been consistently associated with nutritional status. Again, I'll underscore either undernutrition or excess nutrition. And there's been a real increased recognition of nutrition in childhood cancer and nutrition in cancer in general. So if you look at just a basic search in Medline or PubMed, and you can see from the years, 1970 to 79, there were 4 manuscripts on this topic. And most recently, if you look, nutrition, oncology, and pediatrics, almost 700 papers come out. So we really evolved our understanding of what the importance is of nutrition in the setting of childhood cancer. There's some other key factors that have also developed. Children's Oncology Group, which is the largest cooperative group running clinical trials in childhood cancer, incorporated nutrition into their overall vision, into their group vision several years ago. The International Society for Paediatric Oncology established a nutrition committee in 2013. And this has really expanded into other areas of SIOP, including SIOP Africa and SIOP Asia, where nutrition is a cornerstone of these meetings. And then, of course, the World Health Organization has launched a global initiative on childhood cancer, which we all know is really aimed at advancing cure rates around the globe and really leveling the playing field, because as we all can agree, just where you live, any socio-demographic factor shouldn't be the determinant of why you survive or do not survive a diagnosis of cancer. So there's also been a lot of research and progress in research, and I would say in the quality of research that's been done. So again, if you look, real research only started in 1979 to about 1984. And these were really, case series. They were essay pieces. It was a lot of patients thinking about and clinicians really trying to debunk the idea that starving a patient is the best route for cure, and that, we really don't want to feed the patient because that would be feeding the cancer. This led into a number of studies, really finding that actually it's the opposite. If the patient is starving, they have poorer outcomes. And we're now at a stage where we have some very large prospective studies where we can extrapolate information on nutrition as well. And this is really important as more studies in the LMIC setting. So we really need to start understanding the influences and factors relevant to the LMIC setting and what the precise directives must be. And so when you look at Africa as a whole, we know that there's a lot of unmet needs in clinicians regarding nutrition. And this was a survey that we did through the International Society of Paediatric Oncology, where almost 100 institutions were surveyed. And we asked them, what is your barrier to delivering nutrition care? And uniformly, everyone really talked about resources and dietitian availability. Those were the primary two factors. Is that, do we have, all of the nutritional inputs required to deliver nutritional care? And then if we do we have a trained dietitian to do that? So one of the challenges in Africa specifically is the physician to patient burden ratio is just extraordinarily high. And nutrition takes time. It takes a lot of time and patience to monitor, to look at all the labs, to make sure and counsel the patients, because it's really a patient-driven therapy. We can make our recommendations, but a lot of our recommendations need to be implemented in the house. Or even when they're in the hospital, the caregiver needs to follow the regimen that's being written and prescribed for the patient. And then, of course, you need a dietitian who understands the complexities of childhood cancer and how to work within the mandate of that. So we know that in many LMIC settings, there's so many qualified and really well-educated dietitians on the management of community nutrition and even severe acute malnutrition. But layer childhood cancer on top of that, and a lot of institutions kind of shy away from actually caring for these patients from a nutrition perspective because they just don't have the training and the knowledge. So what are some other, challenges faced by pediatric cancer units and LMICs? And I'm going to mention personnel and time. And then you layer on to that endemic rates of severe acute malnutrition as well as malnutrition. So zinc deficiencies, iodine deficiencies, folate deficiencies, all of that really kind of further complicates the management of care and makes their management more complex than just delivering food. It's really comprehensive counseling that's required. And I can't stress enough education and mentorship. I mean, events such as these, here hosted by K&H are outstanding to really get the word out and really educate clinicians who may not have another opportunity to learn about, how you would deliver nutrition care to a child in cancer and what considerations you should make. Now, we know that nutrition improves clinical outcomes. This has been established over and over again. And I will just show this study because it's really compelling, to illustrate the difference in survival that occurs just by feeding a child. So this was a study that was done in Guatemala City. And in this figure A, and I hope you can see where my cursor is, but the dotted line illustrates survival for kids with severe acute malnutrition. And the solid line illustrates survival for those children that maintain regular, healthy nutrition status, normal nutrition status during treatment. You then take these patients, and I want to bring your attention to this dotted line. So my cursor is on it. These were patients that started with severe acute malnutrition, and proactive, aggressive nutrition intervention was implemented. And what you can see here is they have the exact same survival as children with a normal nutritional status during treatment. Compare that to children, these dotted lines that are, down here. These are children that maintained poor nutrition status during treatment or developed it and did not have it remediated. This is about a 30% difference in survival simply by delivering proper nutrition care. So several years ago, about 10 years ago, we established the International Initiative for Pediatrics and Nutrition, and we created a framework for establishing nutrition programs within the context of pediatric oncology. And I will tell you, this talk is not about iParent's framework, but I just wanted to highlight how we've structured these. And then this structure has worked so well that it's now being expanded into general pediatric populations in several other countries around the globe. So what the impact of our model is, it's really delivering clinical care. And what we're finding is that before the establishment of these services, in many of our sites, up to 10% of patients were nutritionally assessed. And those most likely were the most severe patients. And by the end, once we implement a fully functional program, 100% are getting at least a nutrition assessment. And then up to about 90% are getting nutrition education as well as intervention. And then we monitor and evaluate our programs over the course. And this is just to give you, a snapshot of what happens, what can happen simply by establishing a nutrition clinical care program. This was our program in Haiti, and I'll just bring your attention to this pie chart here. You can clearly see that only half this circle of newly diagnosed patients were at a healthy weight. before IPAN. And you can see afterwards, all of our patients were at a healthy weight. So this is what we want to achieve everywhere. And we firmly believe that we can do it. Some other approaches to this, and again, these are all resources before we get in the nitty-gritty of everything, but there are several guidelines that have been developed, and I'm going to refer back to these a little bit later on in my talk. But the International Society for Pediatric Oncology has established guidelines for how to implement nutrition care, but importantly, how to implement nutrition care based on the resources in your institution. We know if anyone spent any time in an LIC or LMIC setting, we always have to adapt care. It's really something that's essential and something that, just is often, unfortunately, a fact of what's needed. But what is, I think, a highlight now is that we actually have guidelines that we can lean on in terms of how to adapt those guidelines and how to move forward in an optimal setting. And so we have different levels of care, of nutrition, and based on the institution's structure, we escalate nutrition care, accordingly. And we know that, again, IPAN and establishing these nutrition programs in and of itself impacts care. So these are two of our sites in Central America and Honduras and Nicaragua. And what you can see is at the very beginning and before IPAN, these institutions were established as a level 1-2, which is kind of a very, very basic nutrition program. And by the end of implementing our full IPAN program, both institutions achieved a level 3. So we were really delighted. That's close to delivering care akin to an HIC setting. So let's get into the nitty-gritty now of what does it mean? What am I talking about nutrition care? And again, I'm going to go over this just generally speaking, always available though for questions at the end of this symposium, as well as available by email. So what are our characteristics of children with cancer at diagnosis in the LMIC setting? Well, they often present with advanced stage disease, and often we're trying to manage abandonment from treatment because we know that there's not pediatric oncology centers everywhere in every rural village, mountainside, seaside, where have you. And so patients always and their families have to travel far to get and get treatment, and that's expensive, as well as takes time away from parents' work. Remediation of undernutrition is really essential. As I explained before, it impacts survival, and it matters, and it impacts toxicity. So how well a child can manage and maintain receiving the treatments without getting, so much toxicity that it's too severe to deliver the treatment, or ultimately in some very severe cases, it can lead to death. Most of the data we know is about body mass index, especially in the LMIC setting. This is slowly changing, but we do know that body composition, so the amount of fat and lean mass you have in your body, greatly impacts outcomes in cancer. Meeting recommendations for physical activity can also be challenging. There's safety issues. There's even access to our opportunities. We need to consider local customs, parental beliefs, and a lot of, how we collaborate with traditional healers. And how you can work with families who really want to seek care with a traditional healer and also conventional traditional medicine. We know that information about diet is limited, but also because of food security issues and a lack of, uniformly available diet variety around the year, that diet quality and variety is very limited in our patients. And then we really, in terms of survivorship, lots more needs to be learned in the low and middle income setting. So components of nutrition assessment, well, it's not different than any other pediatric condition, with the exception of a few items. One, we really stress World Health Organization growth charts, BMI, Z-score growth charts. In order to understand if a child is malnourished, you must use a growth chart. You must plot the patient. You must understand what their Z-score or percentile is in order to develop appropriate plan. I can't tell you the number of, units that I've been in around the globe, in Africa and Asia, particularly, and clinicians will collect height and weight and look at the patient and say, oh, they look pretty small. But in fact, we have no idea if they're stunted. We have no idea if their Z-score is, -3 or -1, because it's not being plotted. Mid-upper arm circumference is really important in that it gives us an indicator of body composition. But in childhood cancer, it's crucial, particularly in patients with solid tumors, because patients come with, a very extended belly. Maybe they have a large Wilms tumor or neuroblastoma. The belly is very well distended. Or, as I mentioned earlier, a lot of patients come with advanced disease. And as a result, they come with very large tumors. Well, that just removes your ability to calculate a BMI, an accurate BMI Z-score, because the weight isn't actual. It's really tumor weight. It's not the weight of the patient. So in those settings, you must use MUAC. We don't even bother with weight, BMI Z-score in those settings because of these distended issues. Height, on the other hand, is not affected by, usually it shouldn't be affected by any sort of malignancy. So in the settings with a large tumor burden, height for age Z-score is required in order to determine if the patient is stunted or at risk for stunting, and then MUAC will give a good indication of what their what their nutrition status is. As the tumor becomes managed and under control, the clinician can then switch to using WHO's BMI for age Z-scores. But until that time, MUAC is the best indicator. So biochemistries are important, but I'm going to be very frank and honest. They're not always accessible. They're not always collected consistently, and it really depends on the clinical circumstance. So because of that, we often lean on clinical exams, especially to look for vitamin deficiencies, and then look at diet history. So between a clinical exam and a diet history, you can get a sense if the patient is eating the same thing every single day, there's no diet variety whatsoever, you can kind of make a very, educated assumption that there's certain nutrients that this patient is more than likely deficient in, and you can act accordingly. So as I mentioned, we have a lot of tools to help institutions. This is a very basic nutrition algorithm, and we really have made it highly functional for the LMIC setting. So depending on whether your patient is at high or moderate risk, and the key factor for nutrition is, can you use the gut? So in a patient with severe enterocolitis, we're not using the gut. So that's, brings us to this section. When your gut's not functioning, what are your next questions? Do you have access to parental nutrition or no? No access or access? And kind of really walk you through what are things you can do. This, obviously this is not ideal. If you can't use the gut, of course you would want to put a patient on parental nutrition or total parental nutrition. But the reality is that's not always available. If the gut is functioning, can you use enteral nutrition? Do you have access to industrialized feeds? What are your options here? And I'll talk about this in a few minutes. The other option here is if the patient's at moderate risk and the gut is functioning, what do you have access to in terms of industrialized feeds or just food, local foods? We use a lot of, local foods to achieve our nutrition goals, and we really have a lot of success in that. So I would not undervalue, the role of peanut butter, the role of coconut milk, all of these very salubrious avocados, variety of fruits and vegetables to get the micronutrients the patients need. All of these things are really beneficial. And with a trained dietitian, you can make dietary plans that meet the needs of the patients. So what are forms of nutrition intervention? Again, at the top level, you have your oral intake, kind of where we go based on that. You have therapeutic diets. I'll talk about this briefly. The neutropenic diet is important in our patient population. And then you have advanced nutrition interventions. So things, a nasogastric tube, a gastrostomy tube, and then, as I mentioned, parental nutrition or total parental nutrition. And how you select these items, your intervention, you're always going to use the gut first. That's kind of rule one in nutrition. Always, always, always use the gut, whether it's through oral intake, whether it's through a nasogastric tube or a gastrostomy tube. Those kind of become decisions based on resources and the clinical situation of the patient. But in either setting, you always start with the gut and then go from there. So ready-to-use supplements, Plumpy Nut, I'm sure all of you are very familiar with it, easy to administer. We can accurately calculate the nutrient intake. It's a low burden for caregivers. A personal opinion about, Plumpy Nut is, do we use it all the time at IPAN sites when it's accessible? Yes. Is it the most nutritious for kids? No. If you have an adolescent with severe acute malnutrition and, this individual needs 1,800 calories a day and 34 grams of protein, it's very difficult to get 1,800 calories, eat enough of these packets because they are so sugary, quite sugary if you haven't tried them. It's, hard for a patient to eat so much. So again, not dismissing RUTF products at all. They are really essential and they save lives. But we have at IPAN sites tried to, and we've successfully done this in 2 countries, one being Tanzania, a close neighbor of yours, and one in Nepal, where we can use local foods and create RUTF products that are healthier and not as sweet and intense for patients. So again, leading to homemade products, we know that this works. There's even been several studies looking at the role of homemade oral supplements in patients with cancer. And in fact, you can remediate severe malnutrition with homemade supplements. You also can maintain nutrition status with homemade supplements. So both of these factors are really important for us, especially in a limited resource setting. And we know it works. Again, you're getting more nutrients in the patient, more variety of food. And from a sustainability and cost perspective, hands down, it is less expensive than using industrialized form food. So again, talking about advanced nutrition support, what do you need to think about? Well, first, do you have access to the devices you need? So you're going to need the formula, you're going to need the tubing, you're going to need maybe pump or syringes, depending. And I'll talk about if it's syringes, how you'll administer that. But usually the number one factor is, do you have the appropriate tube to place? I think that siliconized tubes are really becoming more and more readily available, but not uniformly. And the plastic tubes are really uncomfortable for patients. So, those are also considerations and having to replace them and clean them. You need to ensure that there's clinical oversight and management of feeds. So if you've decided that a patient, they can't eat orally, they have a BMI Z-score of -3, they have a lot of chemotherapy ahead of them, the likelihood that they're going to be eating enough calories and protein to first remediate their malnutrition and then maintain it during therapy is low. So, that's when you're going to want to consider a tube, but then you need to ensure that there's somebody available, trained to provide oversight and management of the feeds. Make sure that there's availability of antibiotics in case an infection occurs. And can the family manage this? So ultimately, and even in the hospital setting, it's the family that is giving the syringe feeds or, giving the gravity feeds. So you need to ensure that the caregiver understands what and how to do. The other thing, if a patient is going home with a tube, you need to ensure that their home environment is hygienic enough so they can clean the tube. Do they have clean water? I mean, we're talking about very basic things, but we know that a lot of our families don't have them. And so if they don't, this might not be, even though clinically it's the best thing for the patient, it might not be feasible depending on other socio-demographic factors that influence your clinical decision whether or not to select this form of nutrition support. So again, if you do have a tube, though, there's two ways, and then we're going to remove pumps are the easiest, but they're expensive and not very accessible in the LMIC setting. Syringe feeding, though, is great. It's very easy. You can do it. Patients can do it themselves. Parents can do it. Really quite easy to do. Other option is gravity feeds, where you could just elevate, just as you see in this picture, and with special tubing and a stopper, you can have the formula flow. I will say my experience with gravity feeding has been lukewarm. You really need, first of all, the bag to be in the right location, high enough. You need the patient sitting in a certain location. You need to have a stopper. We've had a lot of challenges with gravity feeds, but not to say that they're still, the nice thing about gravity feeds is it gives that, it gives the ability to do continuous feeds round the clock, which are important in some clinical settings. I will say that, again, this is just my experience, not something that's been published, but when a child is really nutritionally a mess, maybe, even if they have MAM or SAM and they're getting therapy, they might have a few toxicities alongside, slowly running continuous feeds at 50 ml, 70 ml an hour, 30 ml sometimes, gives better benefit. You'll see faster recovery and more uptake of nutrients by doing continuous feeds versus doing bolus. But that also requires being able to have access to either a pump or these gravity feeds. So I just want to, my last few minutes, I just want to talk about severe acute malnutrition because it's something that we see every day. I know we see it in Africa, outside of the oncology setting, but this is fairly common in about 30 to 40%. In some of the African countries I work in, it's up to 55% of patients at diagnosis also have SAM. So the diagnosis of SAM is the same, with the exception that if a patient has a large tumor, you're not going to be able to use a BMI for HG score. You're going to rely on MUAC, and if there's a presence of bilateral edema. Again, same sort of diagnostic procedures. And I put this table up for resources because this is published by the ministry in Malawi. But what I like about this is it gives very frank measurements in older children and adolescents, which sometimes is hard to come by and removes the need for, kind of searching or plotting the MUAC number on a growth chart. So there's characteristics of a child with SAM, and again, their diet history, the physical examination, all these different kinds of factors that go into whether or not you would diagnose a child with SAM. Now, the problem is that when they have a recent diagnosis, it becomes a little more complex, diagnosing, is this true primary SAM? And they just happen to get a cancer diagnosis on top of it? Or was it the cancer diagnosis and then that developed into SAM? We usually never know. You can do the best you can to try and figure it out. But I do think that there's some key salient factors in a child with cancer and SAM that you don't necessarily see in the primary setting. And I think these are important to understand because they impact how you deliver care. So often when a child has cancer and SAM, they usually have a robust appetite. They're hungry, usually. And that's not always the case if you're in a SAM, in a SAM clinic or in a rehabilitation unit. They often come, because they're conserving energy, not very hungry. Usually, not always, but usually a child with cancer with SAM is still hungry. Their laboratory values may or may not be altered due to SAM. It may be due to the cancer itself. So when you're looking at, the electrolytes may have nothing to do with SAM. They may have to do with the cancer itself. So again, following that F75, F100, RUTF path isn't always the right pathway because the metabolic anomalies may have nothing to do with the malnutrition itself. It may just have to do with the cancer itself, of which there are no recommendations against feeding a child a normal diet if they have, metabolic alterations at diagnosis. You need to think about the demographic factors, again, that will help you distinguish between whether it's a food security issue or it's the cancer. And then again, I bring up infection because it's also one of the factors when you're diagnosing a child or managing a child with SAM. But again, this may be related to the malignancy itself and not necessarily severe acute malnutrition. Some factors that are associated with SAM that are unlikely to be related to the malignancy, any sort of micronutrient deficiency is probably an issue of food security, not the malignancy itself. I say that, there's no research documenting that children with cancer have lower micronutrients than children without cancer at this stage. I guess, the exception would be anemia. Children with cancer and who don't have SAM can be anemic. So again, I, kind of put this up as WHO's treatment schematic of SAM, and just really to drive home the point that these factors may be altered because of the cancer, not SAM itself. And so how you initiate feeds, how you feed the patient may be very different in the setting of SAM and cancer versus SAM in of itself. And so I just want to highlight nutrition education. This is really an important component of nutrition intervention. We need to spend time with patients. We need to teach them about nutrition. We need to advise on how to eat a healthy diet. We could do this in groups. We could do this individually. And again, stressing the importance of food safety. It's really not about avoiding foods in the high income or LMIC setting. It's really about teaching patients about food safety. And we have a lot of tools available to us to do that. But this is really critical because our patients spend prolonged periods of time immunocompromised, and we need to help keep them as safe as possible. So I will end, and I will stop sharing my screen. And thank you all for your attention, and I'll be here for the Q&A session as well. So thank you.
Thank you. Thank you very much, Prof. Elena. That was very comprehensive, sharing your experience and knowledge with us. There's 886 of us here in this meeting, and everyone is picking this, and we need to keep advocating for nutritional support for our children with cancer. Thank you very much. If we have any questions, some have already been answered through the typing. But Prof, we do have a question from an anonymous attendee who said, why do we feed without iron for the first 7 weeks and then give iron after 7 days? No, I think they are referring to that WHO schema you just showed.
Yeah,
yeah. The iron, yeah.
Those are WHO guidelines. And, you know, I have to refresh my memory. I don't recall why you exclude iron the first 7 days. I know there's a biological reason and it's escaping me right now. So I apologize.
Yeah.
But that is in the setting of, you know, initial severe acute malnutrition. Those are the guidelines to follow.
Yes, and I also remember it had a lot to do also with infection, because initially you're treating the hypoglycemia, the infections. There was something about the interaction of iron and infections and antibiotics. We could look at it and we could get back to you that has raised that question here. That's why. Joseph Mwema, your hand is raised. Would you like to ask your question? Joseph Mwema, your hand is up. Yeah, Dr. Njoroge also agrees with me that it's because of infection, the interaction between infection and antibiotics and iron with infection. That's why we don't give it initially. Thank you, Dr. Tess Njoroge, for responding to that as well. Joseph Mwema, are you able to ask your question? Your hand was up. Josephine Bayer, your hand is up. Go ahead. Nelson, are we able to unmute them? The ones whose hands are up? Otherwise, the rest of the questions we responded through typing. As we wait for more questions to come.
Yes, they can post the questions on the Q&A, and we'll be able to respond to them.
Joseph and Josephine, please post your questions on the Q&A. It may not be possible for you to speak, but we've noted that your hands are up. If we see your question, we'll be able to respond. So as we wait for any more questions to come, I wish to invite Barbara. Barbara Muliro is our clinical nutritionist who is working with us in Kenyatta National Hospital with the IPAN program, doing a great job for nutrition with the children with cancer. Maybe she can make 1 or 2 comments, and then we shall invite Mr. Matthew Ngao to give us his presentation. We have a short presentation of 10 minutes from Matthew. Barbara, some 2 comments from you.
Hi, everyone. I'd just like to emphasize on the impact of nutrition and many of the patients, and also the increasing the outcome or even the chances of survival. I can say when my time with the program and seeing the impact that just the nutrition interventions have had on the patients, it actually goes a very, very long way. And when they're through their treatment from the initiation and then through the treatment until they're done and they come back to clinic, I think it's very positive, and it's also very, very encouraging, just knowing that you also had a very important part to play in the survival of that child. So nutrition is not one of those things that should be taken for granted, because it goes a really, really long way and plays a very, very big part in our children.
Thank you, Barbara. We have one more question from an anonymous attendee who is asking, if we are managing cancer with malnutrition, should we give RUTF and it has high levels of sugar? Maybe Prof. Elena, you can take that one.
Yeah. So I alluded to this in my talk. I mean, RUTF saves lives, F100, F7, they all save lives, but they are very high in sugar. You know, and outside of a compliance standpoint, you know, I think you're alluding to, does sugar feed the cancer? So yeah, there is a bit of a concern. It's not a researched or evidence-based concern, but I can tell you that IPAN is trying to minimize RUTF use, in that we try, and we're actually trying to do this at K&H as well, establish a kitchen where we can cook and prepare healthier substitutes for our patients, rather than giving them RUTF. That being said, if you look at the literature, we absolutely know that children with severe acute malnutrition have increased toxicity and reduced survival. So we do not have evidence to show that children who receive RUTF have increased death and increased toxicity. So as of now, the evidence is that it is safe. And we do use RUTF. There is one published study that I was involved with in India, and we did supplement patients with RUTF, and we were looking at outcomes. And I will tell you that that study did not find that in the cohort of children with acute lymphoblastic leukemia, they did not have increased toxicity or death. So I think it's safe, but at this point, the evidence points that RUTF is safe. Can I elaborate on the myth of sugar feeds the cancer? So this is really, I mean, sugar is how cancer, it is the primary source of cancer cells. And oh gosh, it was probably back in the 1920s. There was a kind of landmark article that was written that said, okay, you know, if you block uptake of sugar from tumor cells, you will, you know, essentially starve the cancer. From that work, there was a bit of research looking at the ketogenic diet. So very severe restriction of sugars in cancer. At this point, there's some evidence that ketogenic diets may be beneficial in patients with brain tumors, but in patients with any other type of tumor, there has not been any evidence that that's the case. I think that, you know, you also have to consider that if you're following a true ketogenic low sugar diet, it's extremely difficult to be adherent. And I think even in patients that we know that may have seizures from their tumor, or even just seizures in general, that you know, and we know that there could be a benefit from a low sugar very strict ketogenic diet. Adherence is a real problem. So at this stage though, I can tell you from an evidence perspective, there's no evidence to show that feeding a patient is also feeding the cancer. In fact, feeding a patient, what we find is actually beneficial for the patient, as long as you don't overfeed the patient. So you also don't want to start feeding the patient and get to the extreme end where you're promoting overweight and obesity. And sometimes that happens because there's a mindset that you know, the bigger, the better, the more stronger you'll be. And that's just not the case when it comes to childhood cancer and adult cancer for that matter.
Thank you. Thank you very much, Prof, for that answer. I'll take this opportunity to invite Mr. Matthew Ngao to make his brief presentation, only 5 to 7 minutes. Matthew Ngao is from Abbott Nutrition. They are our sponsor for today, and it's a company that has been working closely also with Kenyatta National Hospital in terms of the supplements that we need for the children with cancer. Matthew, you can make your presentation. Members, if you have any other questions, just feel free to post it because Prof is still here. Thank you.
Hello. Good afternoon, Dr. Irene.
Good afternoon, Matthew.
Thank you for giving me this time to make my presentation. And also thank you, Professor Elena, for your humble presentation. To start with, I know that the first 5 years are a very critical growth period for every child. In that, in the first 1 to 2 years, where we experience rapid growth for our kids, but after we reach 2 to 5 years, the growth is sustained. And every child has an opportunity for growth, but we have 3 barriers of growth during that time. Like difficulties in feeding, whereby children are choosing whatever they want to eat, some range of food, they avoid others. And also, we also have poor nutrition, whereby we find that caregivers are giving more of the macro or micro. So you find sometimes we have deficiency, either micro or macro. Then also we have recurrent illnesses. This is a result of poor immunity. And in Middle East and North Africa is a region with high prevalence of malnutrition, whereby 7 million children are stranded. 3.7 million children are acute malnourished. And then 5.4 million children are overweight. In Kenya, 26% of children under the age of 5 are stranded, 11% are underweight, and 4% are wasted. This is according to UNICEF in 2020. Then more than 16 million children under the age of 5 years do not enjoy nutritious food. And this becomes alarming when you go to West Pokot, when you go to Garissa, Wajir, or Kitui. And if we have insufficient nutrition, is left unattended, usually have growth deficit, and it can contribute to short height, which become permanent. And this one usually have a very big negative impact on our kids, especially on the academic, cognitive, and also the earning potential. But if we are able to screen earlier and intervene using the correct nutritional intervention, we are able to help our kids to catch up and reach their genetic growth potential. Approximately 60% of our adult height is achieved by age of 5. And then when skeletal maturity is reached, all the cartilage is replaced by bone, and there is a fusing of the growth plate. Growth plate usually close near the end of puberty. For girls, that is usually between the age of 13 to 15. For boys, it's between 15 to 17. But early identification and correct nutritional intervention are critical to help restore the normal growth and development before growth plate recloses. As you can see in the diagram here, if we have early intervention, our children are able to catch up. But if we have late intervene later, they might miss the critical window to impact growth. Then when we intervene very late, we have further growth is compromised. I know that the biggest challenge with pediatric oncology kids is intake due to lack of appetite. And this is as a result of therapies like chemotherapy, radiotherapy, and also some form of surgeries. They can also alter the nutrients in the body of the kids. And they usually affect actually the overall survival of the kids, and also their quality of life, and also the treatment tolerance to the chemotherapy or radiotherapy. But with Pediasure, it's made in the simplest form for intake, absorption. Absorption, it has the right kind of nutrients, the right amount, and also to be utilized well to produce energy to our kids' bodies. For over 25 years, Pediatric has been clinically proven to overcome 3 barriers of growth, which are, it is proven for visible growth because it has high quality protein, a unique triple protein complex, and also it has advanced carbohydrate blend. calcium and vitamin D to support bone growth. And also, Paediatric is proven to fill nutritional gap because it's a complete balance with more than 37 essential nutrients. 1 ml gives you 1 kilocalorie. It also has liquid blend with medium chain triglyceride, actually which are easily absorbed, digested, and they utilize very well into the body of the king to produce energy. Also, Paediatric is proven to boost immunity. It has unique symbiotic blend with prebiotic and probiotic. And you learn that in the recent, the gut microbiome has been an area of concern because it's the contributor to the origin and the progression of some diseases. And then you find that it's a form of chemotherapy. They cause gastrointestinal toxicity. And actually, this interferes with the normal bacteria flora function. But with a supplement like Paediatric, it has the both pre and the probiotic, actually to support in restoring the normal function of the gut. And also, we have vitamin C, support immunity, zinc, iron, and also selenium. Paediatric has been clinically proven to deliver physical growth in 8 weeks. And the IUN study did this study for children at nutritional risk. And he found that in 8 weeks, over half of the children, they were able to grow out of bricks weight percentile. Then in 24 weeks, they had improved in terms of weight and also in terms of height. Then IUN also, we have another study for IUN, which was done in 2016 to show the impact of long-term use of oral nutritional supplementation on nutrition adequacy, also dietary and diversity, food intake and growth in Filipino preschool children. And then it is said that Paediatric provides complete balanced nutrition, that's like 50% of what a child requires in just 2 servings. And also, IUN found that children who are fed with Paediatric, they improved in terms of their intake. They ate more fruits, they ate more eggs, vegetable, and meat, and fish. Paediatric has been clinically proven to reduce sicker days by 60%, which actually I know most of the pediatric cancer patients they experience because sometimes they often the immunity is low. But Paediatric has symbiotic blend, a special combination of prebiotic and probiotic, and 20 vitamins and minerals, including zinc, iron, selenium, that help to boost our child's immunity. So, in a nutshell, growth you can be sure with, or recovery journey you can be sure with Paediatric for your pediatric patients who have cancer, because it has essential vitamin and minerals to support the health appetite, which is the biggest challenge here we are addressing. Because if they don't have a good appetite, their intake goes down. Then you find that also their weight also will go also down. So they will not be able to tolerate even the chemo, radio, or surgery. But also we have the protein, calcium, and vitamin D for bone and muscle development. Then the product is very suitable because it's lactose free and also gluten free. Then how to reconstitute Paediatric is 190 ml of water plus 5 scoops. You get 225 ml or 225 kcal. Paediatric actually can be used by children from 1 year up to 10 years. And it can be used as a source of nutrition. That is, I mean, through NG tube feeding. And also as a supplement on top of the other foods our kids are taking, so that we can fill the nutritional gaps. Yeah. That is it from my head, Dr. Irene.
Thank you very much, Matthew, for taking us through that. And about Paediatric, we shall continue to support our children nutritionally while they are receiving treatment for cancer. I can see most of our questions have been answered and responded to. There's one more that just came through. An anonymous attendee is asking, is it safe to start ranferon syrup on a child with severe acute malnutrition and anemia on either F75 or F100 therapeutic milk? Prof, your take on that one?
Sorry.
It's okay, I can go through it again. An attendee is asking whether it is safe to start ranferon is an iron supplement on a child with SAM and anemia on either F75 or F100 therapeutic milk.
Right. So WHO has guidelines for this. So folic acid has its own format of when you will supplement with it. It's a separate supplementation, but you wouldn't start because this contains iron. So you wouldn't want to start on that right away. If that's answering the question. And usually
yes.
F75 and F100, unless, they don't, depending on how they're made, they don't come with nutrients in them. Unless you're having those separate packages that you're putting in and you're adding. So, whether or not they're getting that's somewhat irrelevant unless whoever's preparing it is already adding those multivitamin packets.
Okay, thank you so much. And I think I see we've done most of our questions. There's one, they are saying thank you for the enlightening presentation. And yeah, we start iron after 2 weeks. Monica, yes, that is true. Your comment is noted. Emily is asking, what is the alternative for Paediatric for teenagers, 13 to 19 years? And can it be used as a general supplement, not only for oncology patients? That's for Matthew and Prof.
Yes.
You could respond to Emily.
Yeah. You want me to go for Matthew? Would you like me to answer? You want to go first? Or?
You can go first.
Okay. So I would only advocate for Paediatric if there's a clinical indication. If the patient's able to eat, I wouldn't use Paediatric as a general supplement. I would, that's used as a therapeutic food. There's a condition of why the patient should have it. But if the patient is eating and healthy, then they don't need Paediatric. I would encourage, diverse food. And, maybe if there's some micronutrient deficiency, supplement with that. But if there's some medical condition, that's a different issue. I would just like to comment, someone in here on the chat mentioned about kidney issues, and that would be, I would echo the importance of that topic in oncology at some point, and how we nutritionally manage that. But and I know that's something very relevant that Barbara and I have worked on, so I just want to echo. That's a great comment.
Yeah, we could consider that. Nelson has noted, I've also noted it. In a while, we can plan another session and go through it. I think I would wish, Matthew, you want to say something? Go ahead.
Yes, I want to say something, Dr. Irene.
Yes. Yes,
after now 10 years, we have another product. It's called Ensure. So after we are now attained the age of 10, at 11 years, we start with the Ensure. Actually, to continue supporting the patient in their recovery journey. And also to build nutritional gaps, especially, cancer causes a lot of catabolism. Yeah. So there is Ensure. Yeah.
Okay. Thank you very much for that response. I think, Nelson, I'll invite you to comment about CPD. A lot of participants are asking about their points. And then, Prof, you'll give us your parting shot and we can be free to leave the meeting. It's been very useful and we really appreciate it. Nelson, a comment on the CPD points?
Yes, just as responded to on the chat, all the CPD queries will be answered, or the participants will be replied to via email. We'll have to check what the issue was. So we'll offer much more correspondence via email.
Okay. Thank you so much, Nelson, from our KNH Research Office. Prof, please give us a parting shot, and we are happy to leave the meeting after your parting shot.
Oh, yes. Well, I first want to thank you, the organizers, for inviting me. You know, I hope the information was useful to the audience. If there's any questions, you have Barbara there as your local expert, but I'm also here to help with anything. And I just, you know, really want to underscore that, you know, nutrition care is really important for a child with cancer. So, you know, anything that can be done to support, certainly we're here to help you improve and help take better care of your patients. So thank you so much.
Thank you. Thank you too. Thank you, Prof, Barbara, Matthew, and everyone who attended today. Let's be advocates for our children with cancer, that they get their nutritional support, even as we treat them. Have a good afternoon until we meet next time. Thank you very much. Bye, everyone.
Bye.
Bye.